This conference will now be recorded.
I'll be starting. Right. Good evening, everyone. A very happy Independence Day to all, and welcomes you all in this upcoming seminar. The Association of Emergency Physicians of India continues with our webinar series every 15 days, and today in our webinar we are Dr. Shah Munib Urf Rashid. He is presenting on snakebite. He is presently working as a consultant in emergency medicine, Anil Baghi Hospital, Firozpur, Punjab. He has done MBBS and DNB in emergency medicine from Fortis Hospital, Mohali, and he has a very special interest in emergency medicine, trauma system, and critical care medicine. And he'll be very interested to talk on snakebite. So hand over to you, Dr. Munib. Please continue. Please put your in a slide share mode. And if any queries, kindly post in the chat box. We'll take after the presentation.
Good evening, all. It gives me immense pleasure to discuss this evening about the snake bite and its management, emergency perspective. Happy Independence Day to all. So we will start with the introduction about the snake bite. As we know that snake bite envenomation is a potentially life-threatening disease caused by toxins in the bite of venomous snake. But envenoming can also be caused by the sometimes snakes spitting the venom into the eyes of the victim. So it's not necessary that every time the snake bite victim will present with the bite. We know that there has been inadequate past effort to control this disease. We do not have much data about this disease.
Dr. Shah, just 1 minute. Your voice is a little weak. Can you come near to your laptop? It will be better. Okay. Thank you.
Hello, is this better? Hello.
Yes, better. Huh? Better. Please continue.
Okay. We know that as compared to the other diseases, that the efforts we have made about the snake bite are very weak, especially in our part of the world. And WHO classifies this as the neglected epidemic. And the recently published neglected tropical disease list, the snake bite was one that made into the list. So we have very fragmented and inaccurate epidemiological data available with us as on the snake bite in the subcontinent. Plus, many victims do not attend to healthcare centers or hospitals. Instead, they rely on the traditional treatments, especially when it comes to the snake bites. So we have very poor data available in India, but if we will check the WHO website for the data, available current data shows that 4.5 to 5.4 million people get bitten by snakes annually. And of these, 1.8 to 2.7 million develop the clinical illness. And in India alone, there are 50,000 deaths by snake bites, especially in the rural India. And the problem is that they fail to get the adequate amount of the anti-snake venom. If we will check the websites or the WHO data, you will see the hundreds and thousands of the articles encouraging about this fact that we have very inadequate data and this is a very serious disease. And doctors and both doctors and the other communities are not doing much to deal with this issue. There was a study published by the Indian Institute of Science in 2019 that showed that antivenoms in India are largely ineffective in treating the certain medically important but neglected snakes. So the quality and efforts on the anti-snake venom is also to be modified, and we as emergency physicians can come forward to produce the literature and contribute to the community about this unattended and neglected epidemic. Ophiotoxemia is a term that has been devised to characterize the clinical spectrum following a snake bite and inflammation. And there are 2,500 or some 3,000 species of snake bites worldwide. And of these, only 15% the snakes are venomous or dangerous. Snakes are usually classified on the basis of their morphological characteristics, such as scales, their dentition, their osteology, their myology, their sensory organs. But for our purpose of emergency and medical knowledge, we generally divide the snakes into the four categories. This is the ELAPID, this is CROTALINAE, then VIPERID, and some take hydrophidy out, or others classify it into the ELAPID. In the past, mortality from the snake bite has approached 25%, but with advanced emergency and critical care medicine, availability of anti-snake venom, this has been reduced to less than 0.5. But again, this data is from the US. We don't have the Indian data about the anti-snake venom availability and its efficacy. Typical victim of the snake bite is a male, and usually having the age between 17 to 27 years. 98% of bites are on extremities. Usually it is on hands and arms because of a deliberate attempt of a person to kill the snake. It can be on foot and leg because accidentally while working in farms, patient can step on the snake. Most bites occur between April and September season because this is the time when both snakes and humans are active. And alcohol intoxication has a major role in is a major factor in many inflammations, especially in case of the ELAPID. You will always a typical case you will see an acute flash paralysis patient presenting to the emergency who was sleeping on the floor and who was under the alcohol effect, and then the patient presented acute flaccid paralysis, and then after thorough history you came to know that probably the patient was bitten by an ELAPID family of the snake. For identification purposes, usually we do not have snakes available for identification, but to give a rough idea or to an emergency physician, what can be brought about to you, the patient or an attendant can bring you a snake, and then you may not be able to identify the snake. Identification of the snake is not usually a good approach in case of the Indian scenario, because the identification is mostly done in the West because they have the monovalent kind of the antivenoms available. We always have an antivenom which is a cocktail of 4 antivenoms, and we do not have much to identify, and we do not have much to do after identification of the snake. But still we can identify the snakes which are most dangerous and which mostly need the treatment, and we can identify a non-venomous snake. We usually classify Indian scenario into the ELAPID, VIPERID, CROTALINAE, and Hydrophidae. ELAPID group of the family usually contains the cobra and kraits. Cobras, nobody can miss a cobra because of its peculiar shape and peculiar hood, and having a you will always see in case of media in cinemas or etc. Always a snake will be identified and portrayed as a stereotyped as a cobra snake. Kraits also have a definitive peculiar look. They have this body that has rounded these patches on them, and they usually have the 2 colors. Viperidae or true contains the true or Russell viper, and which we'll discuss further. But Crotalidae family is very important. That contains the pit vipers and rattlesnakes and cotton mouths and copperheads. Pit viper are commonly found in India, but rattlesnakes are not commonly found in India. Pit vipers have this peculiar feature. They have in between eye and nose, they have this pit. These are the heat sensitive organs, which will tell the snake about the approach of a victim. Then you are the Hydrophidae. These are you will not see in clinical settings most of the bites by the Hydrophidae family. Can we guess which snake is a venomous or which snake is non-venomous? Because a definitive diagnosis of snake envenomation poisoning usually requires 2 things. One is the positive identification of the snake, and second is the clinical manifestations of envenomission. But snake is rarely available for identification, but sometimes the patient or attendant can brought up the dead snake or a live snake or a part of a snake for identification. In the absence of positive identification, objective signs and symptoms becomes our main motive to diagnose whether the envenomission has taken place or not. But still, if the patient will or attendant will bring you about the part of the snake, we will study that how will you will identify whether this patient whether this snake is venomous or not. But before studying that, I will tell you that if ever you will be getting a capitated snake or killed snake, be sure that the snake has killed, because there is an intact bite reflex in recently killed or decapitated snakes, and they have capability of inflicting a bite. So this slide I have taken from the NEGM review of the snake bites. This slide again is the overgeneralization of the venomous and non-venomous snake, and again you will see that this mostly applies to the rattlesnakes and the snakes which are look-alike of rattlesnakes and viperidae, because this is the most common problem in their part of the world. In our part of the world, especially in North India, the problem is of the ELAPID more than the problem is with the viperidae. So more the triangular shape of the head, more you will see that this is a viperidae kind of the family, and this is a rattlesnake kind of the family, and more commonly this will be the poisonous snake. They have these long retractile fangs, they have this venomous glands, they have ducts, they have a single row of subcaudal plates, and they have the rattle at the back of their tail. And if these features are not present, and there is a most commonly the rounded head, and the patient snake is having no phalanges, and the anal plate is having the double row of the subcaudal plates, then most probably you will say that this is a non-venomous snake. But kindly please do not do the overgeneralizations. This is only to identify and only to guess, only to keep you back of the mind whether this patient is having venomous snake bite, and then you will eagerly look for the signs and symptoms of envenomission. You cannot decide on the basis of the identification of snake the treatment of the patient, because we have to treat the patient. So what can be the local signs and symptoms? In this slide also you will see that I have highlighted the pit viper bites, because these are the pit viper or Crotalidae family of the snakes which will cause the local signs and symptoms. Elapidae family, you have to make efforts to find out whether there are fangs marks or present or not. Also, most commonly the patient will present with respiratory paralysis or coma or acute flaccid paralysis, and they have very subtle fangs marks present, and you have to make really efforts to find that fangs marks. So fangs marks are commonly present with the viperidae family of the group, and along with fangs marks there will be pain, edema, erythema, there will be ecchymosis at the site, as well as adjacent tissues will be having ecchymosis. So local findings may not be present immediately after presentation of the patient if patient presents very early. So you have to give time and you have to observe the patient. It may take hours or minutes to develop. Pain can be felt immediately, and pain usually occurs in greater than 90% of envenomations by the viperidae group of family, except for the Mojave rattlesnakes. Why this exception was included? Because I want to emphasize the fact that even if pit viperi family, some snakes are present, that they cannot cause the local signs and symptoms, and you cannot rule out on this basis that envenomission has not taken place. Then edema because of small vessel injury, then serous or hemorrhagic delay can form. Lymphadenitis is the most important feature. Sometimes patient can present only with tender regional lymphadenopathy. For example, a patient bitten on the foot, you will see the inguinal node lymphadenopathy and warmth of the injured body part as the only features of the envenomission. Then ecchymosis, as we already discussed. Among the systemic signs and symptoms, most common reaction to the snake bite is terror. The patient is having fear of death, and you will see in all the snake bite management algorithms that first and foremost you have to reassure the patient. That reassurance is only because to overcome this terror, this feeling of impending doom. Patient will say that I will die, I will not survive. You have to always reassure the patient. Why this is important? Because this terror can cause nausea, vomiting, diarrhea, syncope, tachycardia, cold, clampy skin. In short, they will cover all the features which will normally see in any critical patient. So we may confuse these systemic symptoms with the envimation, systemic envimation. This terror is mainly because of a common belief that any bite from snake is a venomous snake, but we know that in fact in pit viper family, which are very dangerous and very venomous snake family, in fact in them also 25% of the bites are dry bites. So these autonomic related reactions of nausea, vomiting, diarrhea, syncope, tachycardia, we need to differentiate it from the systemic manifestations of envimation. Less severe signs and symptoms can be their nausea, vomiting, periorbital or perioral paresthesias, tingling, myokymia, and lethargy and weakness, or rubbery or minty metallic taste, especially in the rattlesnakes. Then more severe can be the same which we see in every critical patient in our emergency: hypotension, tachycardia, tachypnea, respiratory distress, altered sensorium. Particularly, there can be prolonged or unmeasurable INR, hyperphosphatemia, hemolysis, hyperbulimia, hemoconcentration. There can be shock, lactic acidosis, and renal failure. In case of ELAPID family, they will first present the more severe symptoms of them is that first they will present as ptosis, dysarthria, dysphagia. Then gradually they will have respiratory paralysis, or if the patient will present late to the emergency, they can present as respiratory paralysis or coma. These neurotoxic effects may also be delayed up to 12 hours. This is important because we have to observe the patient, and upon the first sign of the neurotoxicity, we have to give the anti-snake venom, because after the full development of the neurotoxicity, we may not be able to reverse the neurotoxicity, especially in case of presynaptic venoms. This again, you will see that this North American classification of the severity of the envimation is based upon the pit vipers. Why? Because this is the problem of them. Pit viper envimation is their problem. We have in our setting in my hospital or in North India, we have most commonly we see the ELAPID group of the family. But in North India, you will see the pit viper family. So most of the classifications and all these literature and data is from the West. So we have to rely upon them only. They divide severity of envimation as a minimal when we have only local symptoms, swelling, erythema, ecchymosis. They have almost no systemic symptoms and almost no coagulation abnormalities. Moderate they define as a progression of swelling. Progression of swelling is very important. This word is very important because progression of swelling is the sure shot indication of giving an anti-snake venom. Then erythema, ecchymosis developing beyond the site of bite. Then there can be non-life-threatening signs such as nausea, vomiting, paresthesias, and hypotension. And they can have mildly abnormal coagulation profile. In severe cases, there is a rapid development of swelling and erythema, and marked sign and symptoms, then hypotension, altered sensorium, then marked coagulation abnormalities of INR, APTT, platelet having less than 20,000. What I emphasize here is that even if there is no local sign and symptoms or very low of the local sign and symptoms present, and you have history of snake bite and systolic blood pressure is less than 70, then you should regard it as a severe envimation. Major family of Indian subcontinent, as I said, that ELAPID, Viperidae, and CROTALINAE. Among the ELAPID, we have common cobras, king cobras, and crate. In Viperidae, we have Russell viper, saw-scaled viper, and in CROTALINAE, we have the pit vipers. Among these, 52 poisonous snakes are found in India, and king cobra, common cobra, Russell viper, crate, and saw-scaled viper are the 5 most common poisonous snakes we found in India. We will study mostly this presentation will be based upon the ELAPID and CROTALINAE group of the families. In ELAPID, we found ELAPID snakes are found throughout the world in warm climates, and most important members are brown snakes or pseudo naga, and tiger snakes, death adders, cobras, mambas, kraits, and coral snakes. As we know that corals are problem of West, and corals are most commonly found in the West. So our book also writes this mnemonic for identification of the venomous snakes. You must have heard it a lot of times: red on yellow kills a fellow, and red on black is the venom lag. But this rule is not available and not always applicable outside United States, and even in United States this rule is not always to be applied. Whenever this red touches the yellow, we say that red ring touches the yellow ring, that we say most probably it's a venomous snake. And if this red ring is if red ring is separated from a yellow ring by a black ring, then most probably it is a non-venomous snake. Then what are the FANGS characteristics of the ELAPID group of family? Remember, the ELAPID group of family, they have their prey based upon the reptile. So they have to inject their venoms in the hard skin of reptile. So they have developed these small, medium-sized, tough, non-ductile, paired, grooved phalanges. They have enclosed venom channels in them rather than hollow venom channels of the viperidic family. ELAPID can exert voluntary control over the injection of venom. Thus, they frequently have the dry bite. ELAPID group of family systemic manifestations is mostly neurological. They will have tremor, salivation, dysarthria, diplopia, bulbar paralysis, ptosis. They will have fixed and constricted pupils, dysphagia, dyspnea, loss of airway control, loss of facial expressions, and seizures. Nausea, vomiting, headache, abdominal pain, and discolored urine can form their characteristics, but mostly they have these neurological features which are forming the most of these symptoms. Immediate cause of death in case of this ELAPID family, that's cobra and crates, is paralysis of respiratory muscles. Except some Australian lapids, they have coagulopathy, and some crates may have rhabdomyolysis. This exception I have included only to emphasize the fact that even in lapid group of the family, you may have coagulopathy and you may have rhabdomyolysis. And as we have already discussed that there are spitting cobras, they are included in the ELAPID group of family, and they cause the venom spit ophthalmopia, and this is a temporary kind of thing, but it's very painful. That causes acute blindness, but luckily it does not cause the systemic inflammation. Conjunctive coagulopathy, thrombocytopenia, ICH, rapid collapse and death, renal impairment, myoglobinuria, coagulopathy, these are all features of the viperidae group of family. But ELAPID group of family can have these exceptional side effects, and we can also call them complications. Myolysins, they are structurally related to the neurotoxins, but instead produce rhabdomyolysis, muscle pain, weakness, myoglobinuria, secondary renal failure, and venom-induced thrombotic microangiopathy. You can see that these all exceptional complications or exceptional effects are present in brown snakes, tiger snakes, Typian snakes, which are not commonly found in India. Correlation of history, as I already said, the typical patient will present with you with a double vision, or the patient will say, I'm unable to swallow clear my throat, and the patient will having dyspnea or respiratory paralysis, coma. So correlation of history is a very, very important diagnosis in the ELAPID snake bites. Why? Because they do not have a particular FANGS marks, they don't have the marked local effects, which will, and sometimes the patient doesn't know that the ELAPID snake has bitten them. So correlation of history, clinical features are very important. Hello? Hello?
Hello. Dr. Shah, you are audible. Please continue.
Oh. And the laboratory investigations only form an adjoint kind of thing in case of the ELAPID snake bites. So PDINR activated APTT, D-dimer, fibrinogen, and CBC, RFT, etc. They all ought to be done in ELAPID snake bite also, but they mostly form a workup of the viperidae bite, because these investigations may not be positive or may not be abnormal in ELAPID snake bite, especially in the early cases. So these tests are always performed prior to the removal of first aid, then after 1 hour after removal of first aid, and at 6 hours and at 12 hours after the bite. Snake venom detection kit is available in many Western countries, especially in Australia. But as I said, that this is not to be used or not available in India because we do not have the monovalent antivenom. We do not gain much of the much by detecting the particular type of snake and particular type of venom. We always have a polyvalent anti-snake venom available with us. So whenever we suspect an ELAPID bite, always admit the patient. Always admit the patient for observation, even if early on early presentation patient may not have any effect especially local, and they may not have systemic effects, still observe the patient for at least 12 to 24 hours. Because bite itself is not so obvious, no local reaction except some cobras. Even with severe inflammation, patient may initially feel very well. They may not manifest clinical features. Therefore, even with severe inflammations, patient may develop neurological features after 2, 6, or 12 hours. Why this is important? Because once they are developed, neurotoxicity is not easily reversed. So we have to be very cautious and pick up these patients at the early signs of diplopia or ptosis. Administration of 3 to 5 vials usually given for the ELAPID snake bites, but we will discuss the algorithms for the dosage also. And if the pressure bandaging and immobilization has been done on the first aid, then you should always maintain this till you will give the patient anti-snake venom. And if after removal of this first aid, the patient develops the features of venomation, then reapply these things. And once antivenom is infused, remove the pressure bandage so that antivenom can reach the enwound area also. Give antivenom only when there's a clear clinical or laboratory evidence of systemic inflammation. And clinical evidence can be tosses, cranial nerve involvement, progressive muscle weakness, as we already discussed. And lab evidence can be the PT-INR, RFT, and whole blood clotting test of 20 minutes, which we'll discuss later. What should be the initial dose of antivenom is always controversial. So simple formula is to follow the product instructions. Why? Because different companies will formulate different products, and you will have different amount of antivenom present, quantity of antivenom present per milliliter of a liquid or a freeze dried product. So a simple formula is to follow the product instructions always, and mainly you have only one type of brand available in your hospital, so you will get used to it and you will get comfortable with it. Administer antivenom IV. If its IV is not available, then IO is an option, but IM is strongly discouraged. But there are certain situations in which IM can also be used, which we'll discuss later. Dilution of antivenom should always be done into 1:10 ratio in the normal saline, and then slowly infuse the antivenom. Then look for the adverse reaction, which are very rarely seen. This is a common misconception that ASV is having a high rate of hypersensitivity and allergic reaction. It is very rarely seen, but you need to look the patient for rash, wheeze, hypotension, and angioedema. And if these symptoms develop, then stop the ASV. Otherwise, gradually increase the rate of the entire dose to 20 to 30 minutes. Should we go for test dosing? No, we should never go for test dosing of an antivenom. And some prescribe a 5-day course of prednisolone, but this is not an evidence-based. In some patients, if you will suspect that patient is having a history of urticaria, angioedema, or there is history of allergies, then you may prescribe after the patient is 5 days course of prednisolone. But this is on case-to-case basis. And pregnancy is also not a contraindication to antivenom therapy. Then we will study something about the crotaline snake bites. These are mostly the pit vipers. As we said that the bilateral pits are present between the eye and nostril. And in India, they are mostly found in Goa, Maharashtra, and southern India. They have these fangs which have empty ducts present, and their prey is the soft mammals. Therefore, they have developed these retractile phalanges which are curved to the which are curved and folded against the roof of mouth. They have no shorter and fixed erect phalanges as we see in the ELAPID family, because they have to bite the reptile skin. Local effects are mostly present in these crotaline, that pit viper group of family. You will see one or more fange marks. The fange marks are associated with local bleeding, pain, progressive edema extending from bite site, then nausea, vomiting, weakness, oral numbness or dizziness. Then again, the same systemic manifestations such as tachycardia, tachypnea, hypotension, altered mental status. And again, these local symptoms may not be present initially, and they may become apparent for 15 to 30 minutes. And even they may not start for several hours. Edema is a problem in the limb, bitten limb, but edema in other parts of the body is more problem. For example, it may cause a rapid onset of angioedema. It can threaten the life of a patient, and compartment syndrome can occur. progressive ecchymosis can develop because of the leakage of blood into subcutaneous tissues. Then hemoconcentration because of the capillary leak syndrome, and hemorrhagic blebs can form within several hours. Now we will study case-based approach. What should be done from the ground till the patient is discharged. So what is the first aid, and is there a really first aid for snake bite? No. There should not be given much emphasis. We have seen the patients, we have given much emphasis of the periphery over the first aid, and then the patient will be delayed to the first center or second center or definitive center, and the patient will get a lot of valuable time is wasted. And you should always know that treatment of snake bite is antivenom. So always transfer the patient as soon as possible to the facility which is having the anti-snake venom present. Don't waste time first aid. If ever first aid is given, then there is a mnemonic, do it right. But you should not be given, I said that you should not.
There is an interruption. Kindly mute every. Hello. Otherwise, you can mute everyone. Please mute everyone. There is a disturbance.
ఫైల్ తయారు చేసి పెట్టాను మరి.
Hello. Hello. Hello.
Hello, Dr. Shah, you can continue.
Okay.
Fine.
So there is a mnemonic, do it right in the field, but you usually say that don't waste time on these steps. So R stands for reassure the patient. As I already said, the main effect and the first and foremost effect is the terror of the patient. So you have always have to reassure the patient that nothing will happen. All snakes are not poisonous. Even in poisonous snakes, all bites are not causing the inflammation. So you have to reassure the patient. But recently there was a publication revisiting do it right approach in Journal of Medicine and Primary Care that included R from removal of LAOs. LAO stands for limb adjoining the ornaments or other constructing materials present on bitten limb. And believe me, if you are in the practice, you will always see the patient presenting the emergency with these limb adjoining ornaments present on them. So in Indian setting, we have to include R stands for reassure and removal also. So remove these ornaments and at the first aid, and remove these constructing materials which usually have a belief that if constructing material is done around the bite, the venomous animation will not take place. So R stands for reassure and removal in our part of the world. Then I stands for pressure bandaging and immobilization of the involved limb above the bitten mark. And you must have seen the presentations and YouTube video in our book also, and Tintinelli also. You will see how is the method of pressure bandaging and splinting the bitten limb. One golden rule is that you have not to kindly mute, please mute. One important thing is that you don't have to do it so tight that you will block the venous supply. Our main aim is only to block the superficial lymphatics. Bandaging is similar as if done for any other kind of sprain. It should be firm, but it should not be tourniquet tight, and you should always be able to insinuate 1 or 2 fingers. So, but if you will see commonly the tourniquet has already been applied at the periphery, don't remove it. In fact, you can inflate the cuff above the SBP and then remove it after giving the anti-snake venom, or slowly release it and see whether the effects and are seen in the patient. So GH stands for get into the hospital, and T stands for the tell care provider your symptoms. And this hospital should always be a facility that has anti-venom availability. Don't waste time the referring patient to first to the primary care, then secondary, then to the tertiary care. Always refer the patient from periphery to the facility that have anti-venom available. So toolkit is the word which is nowadays more commonly in use. and I have also designed a toolkit for snake bite management. You will always need a glass slide, a glass this tube, and some hospitals, in our hospital also we have this point of care PTINR available. If the point of care PTINR is not available, please send the sample to the lab. And third part of the toolkit of snake bit management is antivenom. We have this BE trade venom straight. You can see 4 types of snakes: cobra, crate, vipers, and saw scaled viper is shown on image of this snake antivenom. We have this type of this brand available. You may have other brands available, but mostly in India, the anti-snake venom is composed of anti-snake venom to these 4 types of snake only.
అదే ఒక దానికి హెచ్ఎస్సిటీ కాలేదంటారు. అదే సార్ చెప్పాను, వాళ్ళకి చెప్పినట్టు చెప్పండి సార్. మళ్ళీ
It is a humble request. Kindly mute everyone.
Kindly please mute yourself.
చెప్పండి. వాళ్ళు ఓకే అంటే పైకి షిఫ్ట్ చేసుకోండి. వాళ్ళకి అడ్వైస్ చేద్దాం. వాడు ఓకే అంటే ఓకే, లేదంటే రేపు
Otherwise, you can mute from your.
I'm not able to get that.
There is an option that you can mute from your side. Mute all.
10 నిమిషాలు షిఫ్ట్ చేయమని చెప్పాను.
Sorry for the disturbance. Whole blood clotting time 20 is a simple method. It is recommended by WHO. It can be done bedside, and it assays whether the hemotoxic animation has taken place or not, and whether the patient is a right candidate to give the polyvenom anti-snake. What type of material can be used? Usually it should be the glass, but recently you will see much of the literature that polycarbonates can also be a potential alternative to the glass. But whole blood clotting time in these is within acceptable range of 29.5 minutes. But overall, the plastic containers cannot be recommended as an alternative to glass while performing the whole blood clotting time, because they usually plastic have usually a clotting time of greater than 60 minutes. Another mistake done by usually is that we shake the we frequently in these 20 minutes we shake the test tube to see whether the clotting has takes place, whether the clotting has takes place. But this should not be done. For 20 minutes, don't touch this tube and allow the 20 minutes for blood to settle and get clotted. PTINR can be deranged even if only 15 to 20% of the clotting factors are damaged. And clotting factors, whereas whole blood clotting, it should be at least 50% of the clotting factors should be damaged for whole blood clotting test to be positive. Therefore, a negative whole blood clotting test does not always mean that hematological abnormalities are not present. Therefore, it is always advised that in addition to whole blood clotting test, either a point of care PTINR or the lab PTINR should always be sent in these patients, because it takes at least 50% of clotting factor damage for the whole blood clotting test to be positive. This is the method. Draw 2 ml of the venous blood and transfer it to the glass and make it upright, undisturbed at room temperature for 20 to 30 minutes, and then tilt the glass to the 90 degrees. And if a clot has been formed, this is a normal test. And if the clot degrades, then this is an abnormal. Then there are gradings whether this is a friable clot, or those gradings are very poorly reproducible on the whole blood clotting test. In addition to the normal 5 vitals which we take to the every patient, there is another, we can say there is another vital which has to be taken took in the case of snake bite. That is the SBCT, the single breath count test. It is a bedside spirometry, especially used for ELAPID snake bite patients, and it will, if you will do on arrival single breath count test, you will after 5 minutes, 10 minutes, 15 minutes, half an hour, then you will go on doing these tests. We will see how much what will be the normal counting done in a single breath by a patient. And this is a bedside sort of a spirometry test, which you will if there is an early derangement, you can suspect there is a neurotoxic bite. Now, every bite, even if it is a poisonous species, does not merit the use of the ASV. Anti-snake venom should be given only if the patients in whom its benefits are considered to be exceeding its risks. Since antivenom is relatively costly and often in a limited supply in hospitals, it should be used judiciously and not indiscriminately. What are the risk of reactions should always be taken into the considerations, but what are the usual indications are spontaneous systemic bleeding from distant bite site, coagulopathy, whether the whole blood clotting test is abnormal or INR is greater than 1.2, or thrombocytopenia is present less than 1 lakh, or there is a presence of ptosis, external ophthalmoplegia, or there is a hypotension, shock, cardiac arrhythmias, or there is oliguria, there is a rising urea creatinine, there is hemoglobinuria, myoglobnuria, or there is a rhabdomyolysis. Local swelling, especially the progressive local swelling, progressive edema, progressive swelling involving more than half of the bitten limb in absence of tourniquet, especially within 48 hours, or the swelling after bites on digits, or rapid extension of swelling or development of tender lymphadenopathy draining that bitten limb, is all forms the indications of the anti-snake venom. How long after the patient will present? For example, patient sometimes present after many hours or after days of the venomation. So how long after the patient presents we can give the anti-snake venom? Ideally, the patient should be given anti-snake venom ASAP, but some say that it may reverse the systemic inflammation, especially in case of persistent coagulation abnormalities. As I already said that after some hours, neurological abnormalities or neurotoxicity is not, you may not be able to reverse that. So prolonged coagulation is the only thing that can be reversed by giving the anti-snake venom. So anti-snake venom may be appropriate if the patient presents even after some days, and you can try ASV as long as coagulopathy is present. Whether the anti-venom can prevent the local necrosis, that remains controversial. There is no evidence to suggest that local effects can be prevented from it, but only the coagulopathy can be reversed, and you have to try if the patient was not given anti-snake venom and presents after several days of the viperidae bite. Despite widespread use of antivenom, the ideal dose needed is still not known. You will find different books, different literature, guidelines of West, guidelines of WHO, National Health Mission guidelines, all will have different sort of the doses available in their algorithms. Somehow you will see that initial dosage is still agreed upon. It is 6 to 10 vials, but total dose is still debatable. Theoretically, there seems not theoretically we can say that there should be an upper limit of anti-snake venom which should be given, because there should be an upper limit of the ability of a snake to inject the venom. So even some literature says that even 45 vials, 4,500 units have been used successfully in patients. And symptomatology is not always useful guide to suggest it at what level the inflammation has taken place. So you can adopt any ASV regime in your hospital, and with practice you will gain the necessary expertise of how much anti-snake is used in what type of bite. What is important that a particular single protocol should be established in your hospital, and that should be adhered to, and that should order to enable results to that should be readily reviewed after some time. Studies have suggested total dose required will generally be between 10 to 25 vials, as each vial neutralizes 6 mg of Russell's viper venom. Not all victims will require 10 vials, as some may be injected with less than 63 milligrams of venom, and not all victims will require 25 vials. So a starting point is always 6 to 10 vials, ensuring that there is at least sufficient amount of ASV providing to the patient that neutralize the most common amount of the venom injected by the Russell's viper, that is 63 mg. There is every chance to detect remaining free-flowing viper venom by a whole blood clotting test done at 6 hours from completion of first dose of 10 vials. So additional second dose can be given after 6 hours of first dose if we will see coagulation abnormalities are still persisting. Problem with most dosage regimes, including the regimes which are present in most of our readable textbooks such as Harrison, Tintinelli, they're all based on the US data. We do not have Indian data available. So in 2016, National Health Mission published the guidelines. They tried to give a guide to physicians about total dose of ASV that can be administered. The amount of venom injected by the snake is not infinite. They made this guideline on the basis of this theory that amount of venom injected by the snake is not infinite and it will have an upper range, and therefore there should be a tendency among physicians to believe that more ASV is better and to continue using ASV past the point where the amount of ASV given is in excess the maximum amount of venom possible. This is both wastage of resources and expensive. So I have also seen that many of our colleagues that they always say that more ASV will give more is the better. That is not always the case. There is a finite amount of the venom injected by the snake, and there should be an upper limit, and ASV should be used judiciously. Believe me, after every snake bite patient present at our hospital, we get out of the ASV. So the ASV is not readily available. Hardly every hospital has a 10 or some 15 vials present, and if you will get God forbid in these months 2 patients of snake bite, you will get exhausted of your ASV resources. So you have to use it judiciously. National Health Mission has developed this algorithm. You can use any algorithm, but National Health Mission, according to the Indian scenario, has developed this algorithm. For ELAPID bite of neuroparalytic type of, we give ASV 10 vials stat as infusion over 30 to 20 minutes. Then we will follow the second dose after 1 hour or after 6 hours, only if the symptoms do not improve. For vascular toxic snake bite, 2 regimes has been proposed. One is the high dose regime and one is the fast regime and one is the slow regime. In fast regime, 10 vials of Russell viper or 6 vials for soft scaled viper. Again, we do not have particular vials for Russell viper and particular for soft scaled in Indian scenario. We have only one type of antivenom available. So we will have to give the 10 vials in again this setting for 30 minutes. Then 2 hours every 6 hours in an infusion of 100 ml saline till clotting time and those abnormalities will get cleared. And you can use it up to 3 days, whichever is earlier. Or you can use the 10 vials ASAP stand in 30 minutes. Then you can follow 6 vials 6 hours as a bolus therapy till the clotting time is normalized or local symptoms are subsided. So we have 2 types of regimes here. Either the 2 vials, that is slowly giving, this is slow regime, 2 vials every 6 hours early, or 6 vials every 6 hours early. This is the fast regime. Both have been seen in the literature. Both are effective, and you need to apply one of these into your protocol at your particular place. What is the rationale of this dose? As already discussed, that mostly we have seen that Russell viper injects 63 milligrams of venom, and this is the basis that we have devised that these 6 to 10 vials should be injected. So our initial dose is calculated to neutralize the average dose of at least this amount should be neutralized by our initial dose. But this range is also not. This is not that always 63 milligrams of venom will be injected. This is also range from 5 to 147. Therefore, you can need from 10 vials to 30 vials, as each vial neutralizes the 6 mg of Russell's viper. Again, I will emphasize the fact that all this literature is based upon the Russell's viper venom, and all this data comes from the West. What are the adjuvants we can use to the ASV? Epinephrine, as it is the drug of it is the life-saving drug of every emergency physician, and it should always be available at bedside. Firstly, to prevent the antivenom side effects, and there are 2 methods of injecting it: either the intravenous push injection or intravenous infusion. 10 vials are dissolved. This is the presentation that 10 vials will be dissolved in 100 ml of distilled water, or added to the 400 ml of saline. Antivenoms should always be given intravenous. They should never be given intramuscular because they are large molecules, and the large size of them will prevent them absorption into the lymphatics. Therefore, bioavailability will be poor. But WHO guidelines suggest that there are three situations in which you can consider, but it should always be tried to give intravenous. In absence of any one capable of giving an intravenous, for example, at peripheral hospital first aid station, when you know that going to the hospital which has ASV available will take several hours and it may not benefit the patient. And for example, you are in the remote possible areas in some expedition or some hill or some such kind of thing, while you know that medical care is not going to be available for several hours. And when intravenous access has been tried and it was almost impossible. We have to always bear in mind what ASV can do and what ASV cannot do. If we will make this concept clear, then we will understand that ASV is not, it will not reverse the local effects. It will not reverse whatever coagulopathy has taken place. It will not reverse whatever renal failure has taken place. Only purpose of ASV is that the venom which is not bound, make it bound to the antivenom instead of binding to the blood or tissues. It can only do that thing. It can neutralize the venom by making it not to the bound to the tissues and other things. Whatever damage has been taken place, that has to be managed conservatively by other sort of the treatment. For example, renal failure has been managed by acute kidney injury guidelines, or coagulopathy by infusing the FFPs or platelet transfusions you may require. So ASV can only do, it will prevent the further harm. Whatever harm has taken place, it cannot reverse that. In case of the ELAPID family of group that's neurotoxicity, patients may benefit from anticholinergics. I previously included the pharmacology of the snake venoms, but it was getting too lengthy. If you have interest, you can study the pharmacology of the venoms. Venoms contain several thousands of enzymes, and mostly these enzymes have been elucidated what they contain. And phospholipase A2 and cholinesterase are the most important form of the enzymes present in them. So therefore, they have cholinesterase present. Therefore, anti-cholinergics, neostigmine trial has been given, and anti-cholinesterase therapy is beneficial. And but you have to give as we give in the myasthenia gravis. We have to give first trial of IV or IM 0.5 milligram of neostigmine along with the atropine to prevent the muscarinic effects, and then observe the patient. If you will see that neostigmine administration has created a marked improvement in paralysis of the patient, then you continue the neostigmine every 20 minutes until the muscle strength is recovered. And subsequently it can be given IV every 2 to 4 hours as needed. But first and foremost, you have to go for the test. Either you can go for adrophonium test or neostigmine test, but test is to be done. If it is, if you will see that no effect has been taken on the first dose, then no need to give the additional doses of neostigmine or adrophonium. Then, as I already discussed, that fresh frozen plasma you may need platelet transfusions to maintain the platelet above 1 lakh. As we know that tetanus prone are these snake bites, so always give the patient tetanus prophylaxis according to their status. Antibiotics are not empirically given, and evidence doesn't support their empiric antibiotic treatment, but you will have to use it on the case-to-case basis based upon the course of the patient that will follow in the hospital. Thank you.
Thank you, Dr. Shah, for the nice presentation. It was quite informative and evidence-based too. I hope it will be very helpful for the delegates, not only for their clinical, but their postgraduates for their exam purposes, because these are the few tips and all the recent advances they should be aware of. There is a one query in the question chat box. What about using TAG, thromboelastography, instead of PT-INR? Can you clarify?
Yes, TTG, the tag is used, it is not readily available in India. I have seen this only available in AIMS Delhi. Even in Fortis, we do not have tag available. But yeah, if it is available, this is a very good and very important test and very helpful test to immediately give us status about the coagulopathy. Mostly literature suggests its use in the traumatic coagulopathy. And this is a very costly test and a costly machine, so I don't think it is readily available in everywhere in India. So
Yeah, but
because
it's available. It is highly sensitive.
Snakebite is the
You
thing
can tell
which is
exactly what is the deficiency, where is the deficiency and what component has to be replaced.
yes, ma'am. But since the snakebite is the thing which is most commonly will see the patient presenting in the peripheries and rural areas where the settings are not appropriate, therefore WHO has always recommended this simple test of whole blood clotting test of 20 minutes.
Yeah. Good evening, Dr. Roshan. Any other questions? You can unmute and then ask. If anybody have any queries. Dr. Obaid is saying thank you so much, Dr. Shah. Very nice and comprehensive presentation.
Thank you.
Okay. Thank you everybody for the patience hearing. And we are continuing with these kind of webinars every 2 weekly. We'll give the sessions, whatever we are having planned, upload in the Pan India group. And also we are going to take a mock practical exam. So we'll give the date soon. Best wishes to everyone. Thank you, Dr. Shah. Thank you, everyone. I hope we can end the meeting.
Thank you.
Thank you. Dr. Santosh, you want to say something? Dr. Santosh, Dr. Krishna.
Dr. Santosh is there.
Dr.
Dr.
KP.
Shah, I mean, I like the talk. I mean, the talk was very good. About, like almost everything, starting from the pathophysiology and identification of snakes and everything. So, from a theoretical and exam point of view, I think this is very good. And you know, the question regarding to tech and everything. Obviously, these are few things which could be asked in the exam. Mostly, questions which are asked in the exam are not really practical based. They're most theoretically based.
Yeah.
So they want candidates to write a long essay or something like so. Obviously, the questions which could be asked was also covered in this talk. So, from a practical point of view, you were right. Yes, there are no Indian guidelines for a lot of things in snake bite management. But having said so, yes, we can come up with new policies, but that is what we are as future emergency physicians would like to contribute. And so yes, 10 vials is the standard approach. There used to be different vial methods. Some used to say go with 20. Some had their own institution-based protocols. I think at the moment we continue with what the National Health Mission guidelines say, and then see what else we can contribute. This talk is very good. Voice is very nice. I mean, it's very clear. Just one suggestion. You know, the slides looks a little crowded in some places, but otherwise everything else is fine.
And congratulations for being the part of the core member group. And we welcome all the young faculty to become the part of this member and have these participations and these kind of presentations. Thank you, Dr. Krishna. Thank you, Dr. Shah.
Thank you.
We'll announce the date for the mock practical exam soon.